Good afternoon. Welcome to today's webinar, Digestive Insufficiency, Dysbiosis and Disease, Implications for Personalized Therapies. Today, our presenter is Dr. Tom Fabian. A little about Dr. Fabian. He is a functional nutrition practitioner, consultant, educator, speaker, and former research scientist. His primary expertise is in how the microbiome interacts with digestive, immune, and nervous systems, and how it influences metabolic processes. He has developed online educational programs for practitioners seeking in-depth education in the microbiome and related topics. He also has extensive experience in the areas of aging and health span optimization, both through his previous research experience as well as his more recent experience as a functional health practitioner. Tom is also a valuable part of the medical and scientific advisory team at Diagnostic Solutions, and we are glad to have him this afternoon. So, Tom, I will give you the floor.
All right. Well, thanks so much, Jeff, and welcome everybody to the webinar. So today the topic, as Jeff mentioned, is going to be focused on identifying signs and patterns related to digestive insufficiency and how that relates to dysbiosis using GI map. So really it's about connecting the dots. So over time, as you're using GI map, you start to connect more and more of the dots in terms of the patterns and how that can relate to various imbalances in patients and clients. And digestive dysfunction is actually one of the major aspects of what we can see with GI map, both in terms of the microbial markers as well as the intestinal health markers. So let's talk a little bit about the basics of digestive dysfunction in terms of what we can see on GI map. So typically digestive dysfunction involves hypochlorhydria many times, as well as maldigestion, malabsorption, sometimes bile acid insufficiency, and then also dysbiosis. And it turns out that dysbiosis or imbalances in the microbiome actually can be both potentially a cause as well as a consequence of digestive dysfunction. And we are going to be focusing on that quite a bit in this webinar. Just want to talk a little bit about some of the common consequences and symptoms that are typically associated with digestive dysfunction and digestive insufficiency. One of the major ones, and again, this is something that we see a lot on GI map, is an increase in susceptibility to various infections. And of course, as you can imagine, that's related in large part to hypochlorhydria, which results in basically the survival of some of these pathogens as they're passing through the GI tract. Some of the other consequences include diarrhea, especially related to osmotic diarrhea, which has to do with a lack of digestion because that increases the osmotic load in the small intestine and especially in the colon. And then there are other types of diarrhea as well that are related to digestive insufficiency. Also, alternatively, it can lead to constipation, depending on the details of what's going on in an individual patient. We will be talking a bit more about that as well. Excessive gas is another common consequence of digestive insufficiency, and primarily that can be due to excessive microbial fermentation. So again, as you can imagine, when digestion is not sufficient, that provides additional substrates or additional food sources for microbes to basically fuel their growth and fermentation processes that can result in various types of gases, including hydrogen and methane. Chronic inflammation is often a common consequence of digestive insufficiency, partly due to these changes in the microbiome that can be fueled by digestive insufficiency and digestive dysfunction. And then, as you can imagine as well, when nutrients are not digested and absorbed properly, then that can, of course, lead to nutrient deficiencies. And all of these, as you can imagine, can then sort of feed back on one another in a vicious cycle, and that can lead to further compromise of digestive function. Let's talk a little bit about some of the most common causes that contribute to digestive insufficiency. So this is, again, an area we're going to focus on quite a bit in this webinar, and that's enteric or gastric infections such as H. pylori and Giardia. Inflammation as well as autoimmune processes can contribute to digestive insufficiencies. Stress and just generally autonomic imbalances between the parasympathetic and sympathetic nervous systems. Various medications can actually contribute to digestive insufficiency. One of the most obvious ones, of course, would be proton pump inhibitors and other types of acid suppressors. But it turns out there are other types of drugs that can also impact the ability of the gastrointestinal system to fully digest and absorb foods. Then actually diet and supplements can contribute to some extent as well. All right, so let's talk a little bit more about the relationship between digestive insufficiency and dysbiosis. So as I mentioned, some pathogens can cause chronic hypoacidity. The most obvious one that typically comes to mind would be H. pylori. And it turns out that it's pretty well established that chronic H. pylori infections, by and large, can lead to hypochlorhydria. And then that consequently can lead to malabsorption. Giardia also is another pathogen that's been well established to contribute to malabsorption. And then in turn, hypoacidity and malabsorption contribute to further dysbiosis. And these are all patterns that we actually commonly see with GI map. And so this is a really big part of what we want to do in this webinar is help you connect the dots when you're looking at the results for a given patient and you see all these various markers for pathogens, normal flora, opportunists, and then also looking at the intestinal health markers. How do you connect all those together to recognize these patterns and see if there is a potential impact related to digestive insufficiency? So really, I think a common way to think of this is sort of the domino effect. Of course, there's sort of this sequential process that happens throughout the whole digestion process. And if you think about the further digestion steps that are triggered by, for example, stomach acid, and that, of course, triggers bile acid release, triggers bicarbonates in the small intestine, can trigger the release of various types of digestive enzymes. All of these steps are really necessary. So if there's a defect or something interfering with an earlier step, of course, that can cascade down throughout the whole rest of the process and again lead to dysfunction. So I want to dive into a couple of cases here just to start illustrating some of these patterns that we see and how that can relate to symptoms and conditions. So in this first example, these are just very quick examples that we're going to be going through. But this is an example of a 41-year-old female with a very high stress level. And she reports chronic diarrhea, chronic bloating, lots of gas production, especially malodorous gas, acid reflux, and it's suspected that she may have SIBO, although that has not yet been confirmed in this case. And then she also has a history of being on proton pump inhibitors. And these are the results from her GI map. So you can see the first page, which is basically the section on pathogens, is largely clear except for some Giardia. So in this case, the Giardia level is not flagged as high. So you can see down here towards the bottom that Giardia is at the 3.07 E2 level, which is less than our target for being flagged as high, which is 5 times 10 to the third, or 5 E3. So this is kind of one of the points that I wanted to emphasize here is that with a number of these different types of pathogens and opportunists, it's not always necessary to just pay attention to them when they're flagged as high, but potentially in some cases, even when they're not at excessively high levels, they can still impact physiology. And that's seen more often with certain microbes than with others. And Giardia does appear to be one of those cases where we frequently do see it present at sort of moderate levels, and yet it does appear to be contributing to symptoms. And on the next page, we see H. pylori in this particular patient was negative. And in terms of the normal bacterial flora, we see kind of a range of imbalances here. So you can see that the first two listed that are low, Enterococcus and Escherichia, are both relatively low compared to the Clostridium and Enterobacter, which are both flagged as high. And then the other notable marker on this page is the Bacteroidetes phylum, which is also high. So again, when you're new to GI map, sometimes it's not always clear how to interpret these sorts of variations or imbalances. I will mention that we do have, and I'll display that at the end of the webinar, that we do have a guide sheet for you to start to recognize these patterns. So you can refer to those sheets to understand better these different markers that make up the patterns. So in this case, we've already associated certain markers when they're high to digestive insufficiency. And in particular, when you do refer to that guide sheet, you'll note that some of the ones on the list include Clostridium, which we frequently see elevated in situations where digestion is not optimal. The other one that really stands out on this section here for this patient is the Bacteroidetes under the phyla. That is one of the groups that we tend to see relatively high frequently when digestion isn't optimal. In particular, those two groups, the Clostridium group and the Bacteroidetes group, tend to be high, especially when stomach acid is not sufficient, for example, and when proteins are not digested as well as they should be. When we go on to the next section, the opportunistic bacteria, you can see there's a few markers here that are noted and also out of range. In particular, Streptococcus is elevated, as well as Prevotella copri. And again, as we kind of go through this webinar and talk about the various patterns, you'll see that these are basically patterns that we commonly see when certain macronutrients are not digested well. So Streptococcus, it turns out, is really highly related to reduced stomach acid. That's been shown both in research and it's something we see clinically very frequently. Prevotella copri is a species that depends quite a bit on carbohydrates as its main food source. So we tend to see it elevated, especially when carbohydrates are not digested fully as well. Another marker that we often see elevated when there is digestive dysfunction or digestive insufficiency is Candida. And again, in this case, Candida is not flagged as high. It's fairly close. You can see that it's at the 3.34 e to the 3 level, and the cutoff is 5 e to the 3. So it's fairly close to that level. But oftentimes we will see even low to moderate levels of Candida register on GI map when there is this digestive insufficiency pattern. So that's again a very common marker to see present along with this pattern. The parasites page looks pretty clear. None of the protozoa are detected. None of the worms are detected in this patient. And if we look at the intestinal health markers, you'll note basically everything looks kind of on the surface relatively okay. Nothing is flagged as high or low. However, when we kind of zero in on elastase, that particular marker is trending on the low side. So that's something that we want to note and is consistent with an overall reduced digestion pattern in the case of this particular patient. Just want to note as kind of a guideline that typically we consider optimal levels for elastase to be around 500. So again, 303 is significantly below that level, even though it's not officially flagged as low. It's a trend towards the low side. So that does support that there probably is some level of deficiency in the output of digestive enzymes by the pancreas. Other than that, everything looks fairly good in terms of the intestinal health markers in this particular case. So I want to mention just a little bit of research about some of the markers that we just talked about and how they can be related to digestive insufficiency and digestive dysfunction. So we noted again in this particular patient's case that Giardia was present, not necessarily at a high level. So just want to talk about this particular marker a bit more. So this is a review article that came out a few years ago on Giardia and presents some nice summary information about Giardia. So in the article they say, Giardia is the most prevalent human intestinal parasitic protist in the world and one of the most common parasites of companion animals and young livestock. Giardia is a major cause of diarrhea in children and in travelers. They go on to say findings available to date indicate that the infection causes diarrhea by a combination of intestinal malabsorption and hypersecretion. Malabsorption and maldigestion mainly result from a diffuse shortening of epithelial microvilli. So right there you can kind of visualize that that's one of the factors that's impacting the small intestine's ability to fully digest and absorb nutrients, since the microvilli provide the surface area as well as the brush border enzymes that are needed to contribute in a large way to digestion and absorption. And they go on to say pathophysiological activation of lymphocytes is secondary to Giardia-induced disruption of epithelial tight junctions, which in turn increases intestinal permeability. So they mentioned here there's a little bit of an inflammatory component. That's one of the things that we noted earlier is a common contributor to digestive insufficiency. And then a result of a lot of this oftentimes is increased intestinal permeability, which then can cascade down into causing further symptoms related to food sensitivities, for example. They go on to say recent findings suggest that these effects may facilitate the development of chronic enteric disorders, including inflammatory bowel disease, irritable bowel syndrome, and allergies. So again, just from one particular microbe, there's the possibility of these long-term imbalances that can lead to other diseases. So again, may look to be fairly harmless on the test, especially if it's not high, but in the context, and that's really something I want to emphasize is you really need to put these results in the context of the overall test itself, as well, of course, in the context of the patient. Okay, so the next article that I want to focus on is this one titled Giardia Alters Commensal Microbial Diversity Throughout the Murine Gut, which basically means mouse gut. So this is a recent article that came out a couple years ago. And in the summary, they say Giardia colonization and proliferation in the small intestine of the host may, however, disrupt the ecological homeostasis of gastrointestinal commensal microbes and contribute to diarrheal disease associated with giardiasis. And then they go on to say, we discovered that Giardia's colonization of the small intestine causes systemic dysbiosis of aerobic and anaerobic commensal bacteria. So again, this is really emphasizing new information that's been coming out that Giardia in and of itself may be actually causing a lot of its symptoms through inducing dysbiosis throughout the whole gastrointestinal tract. So a couple other important points is that we know that Giardia is primarily an issue in the small intestine, especially the duodenum. So that's its primary site of infection. Of course, in that context, it can affect the digestion and absorption ability of the small intestine. But because of these downstream consequences that have to do with malabsorption, that have to do with leaky gut, and especially that have to do with widespread dysbiosis, we can actually see the impact of Giardia in a stool sample, which is actually, of course, from a GI standpoint, fairly distant from the duodenum, and yet we can actually see the effects. So again, this is just kind of reinforcing that there are these imbalances, and we can pick them up with GI map. I also want to emphasize, so this particular patient had a history of proton pump inhibitor use, which it turns out is also something that's known to disrupt the microbiome. So this article is titled Intestinal Dysbiosis Secondary to Proton Pump Inhibitor Use. And they go on to say gut dysbiosis associated with the use of proton pump inhibitors has been found to lead to the occurrence of infectious and inflammatory adverse events. Then they go on to say in the next section, PPI use significantly increased the presence of Streptococcacea, Enterococcacea, which are risk factors for C. diff infection, and then decreased Faecalibacterium, a commensal anti-inflammatory microbe. So again, this is alluding to the fact that PPIs do cause changes in the microbiome, and then of course there can be some consequences to that. But these are actually markers that we can see on GI map, and it is something that we strongly tend to see when patients have been on proton pump inhibitors. The other thing to note here is kind of this multifactorial effect where we know that certain pathogens can cause digestive dysfunction. PPIs can cause issues as well independently, but then PPIs can actually increase susceptibility to infections. So that again can lead to this sort of cascade effect. A second article emphasizing even further that proton pump inhibitors can disrupt the microbiome is this one, titled Proton Pump Inhibitors Affect the Gut Microbiome. And in the article, they say proton pump inhibitors are among the top 10 most widely used drugs in the world. PPI use has been associated with an increased risk of enteric infections, most notably Clostridium difficile. The gut microbiome plays an important role in enteric infections by either resisting or promoting colonization by pathogens. So it really depends on the individual microbiome. In this study, we investigated the influence of PPI use on the gut microbiome. They go on to say in PPI users, we observe a significant increase in bacteria, the genera Enterococcus, Streptococcus, Staphylococcus, and then potentially pathogenic species E. coli. So let me go back up a minute here to the results for this patient. And so we can see here under their opportunistic bacteria that they do have a bit of this pattern that was just mentioned, in particular the presence of high levels of Streptococcus. In this case, this particular patient didn't have Enterococcus, but they also do have Staphylococcus. So they have two of the three that have been noted in multiple studies to be linked to PPI use. So again, this is something that we see very frequently clinically with GI map. Let me go back to... Okay, so this next article that I wanted to focus on is titled Microbial Fermentation of Dietary Protein, an Important Factor in Diet Microbe-Host Interaction. So this is referring to, before I dive into the details here, the fact that when you don't have adequate digestion, that's going to affect a lot of things, of course, but in terms of the macronutrients, we're primarily talking about, of course, the top three macronutrients: carbohydrates, fats, and proteins. And it turns out that each one of those, when they're not digested fully, has kind of a whole spectrum of effects and consequences that are specific to that type of macronutrient. And so it turns out when proteins are not fully digested, there are a number of different consequences, including something called protein fermentation, which happens in the colon. And that process actually can generate a lot of potentially toxic products. So that can be one of the consequences related to inadequate digestion of protein. So they go on to say in this review, a review of recent studies paired with findings from previous culture-based experiments suggests an important role for microbial protein fermentation in altering the gut microbiota and generating a diverse range of bioactive molecules which exert wide-ranging host effects. These metabolic products have been shown to increase inflammatory response, tissue permeability, and colitis severity in the gut. They are also implicated in the development of metabolic disease, including obesity, diabetes, and non-alcoholic fatty liver disease. Specific products of proteolytic fermentation, such as hydrogen sulfide, ammonia, and P-cresol, may also contribute to the development of colorectal cancer. So just one other thing I want to note here, I didn't actually include this study in this webinar, but there was a recent research study that came out showing that protein fermentation in general, and particularly P-cresol, this product that was mentioned in that last sentence here, that's a product of protein fermentation, actually is something that is produced by Clostridium difficile and gives it a competitive advantage. So when we talk about the link between proton pump inhibitors and hypochlorhydria, low stomach acid, and increased risk for Clostridium difficile, that's potentially one of the factors. It leads to, the lack of stomach acid leads to potentially an increase in protein fermentation in the colon, which then benefits Clostridium difficile. It gives it a competitive advantage. All right, so with some of that research out of the way, to kind of put some additional information and light around interpreting the results from the previous case, I want to talk about another case here. So this is a 37-year-old male who owns his own business. So he has very high work-related stress and also noted fairly high levels of family-related stress. He's suffering from severe reflux, also has a history of being on proton pump inhibitors, exhibits SIBO-like symptoms that have not been confirmed in terms of breath testing, and also suffers from frequent what's generally known as postural orthostatic tachycardia syndrome. So essentially, when he stands up abruptly, starts to feel faint and feels like he's going to pass out. All right, so his results on GA-MAP show, I'm just kind of zeroing in here on the opportunistic bacteria section just to illustrate initially that pattern that we tend to see with PPIs in low stomach acid. So we talked about those previous two studies that basically discuss the fact that Enterococcus and Streptococcus are two of the most common groups that we tend to see overgrown in those that are on proton pump inhibitors. And as you can imagine, for those that also have excessive stress, stress itself will also decrease the secretory activity of the GI tract, including stomach acid. So potentially the two of those together can lead to a fairly strong pattern, again, which is something we do see here, where both Enterococcus species listed in the opportunistic bacteria section are relatively high, and then Streptococcus is also notable for being high in this case as well. And this really is not only something that's been confirmed time and again in research, but it is something that we see clinically all the time. Okay, so going back, starting from the beginning of his results, he's clear on other pathogens. So in his case, he doesn't have any C. diff, for example, or any other pathogens. In this case, H. pylori is not an issue. Normal bacterial flora shows some of the expected pattern, especially with high Clostridium, high Bacteroidetes, and high Firmicutes. I mentioned that SIBO is suspected in this case based on symptoms, and high Bacteroidetes and high Firmicutes is something we frequently see in SIBO situations. No Candida present in this case. No other parasites or worms are present. Once again, as I mentioned with the last case, elastase is a bit on the low side. Again, optimal is around 500. So this level of 297 is trending on the low side. Otherwise, his markers are fairly good except for secretory IgA. Now that's something that can be low frequently with low levels of certain types of beneficial bacteria. So it's certainly common to have, in terms of the overall imbalances, you can have overgrowth of certain groups, and then you can have other groups that are deficient. Just a side note is that one of the groups that seems to be among the most important for promoting secretory IgA are the butyrate producing bacteria. So in this case, this suggests that this patient may benefit from support for those particular butyrate producers in particular. Other than that, really nothing else is too far off. We do see that calprotectin is, it's not considered high in this case yet, so it's not above the cutoff level of 173, but we do see that it's well above 100, which still suggests kind of a moderately elevated level of inflammation. So this is all consistent with just a general pattern of dysbiosis in what we know about the effects of stress. So in this case, we don't see a particular trigger in terms of a microbe that may be interfering with digestive activity, but we do see a pattern that's likely related to PPI use and probably stress. Okay, so just want to dive into another example here. So this is a 40-year-old female who basically reports high stress and chronic fatigue, also chronic constipation, and has been diagnosed with eosinophilic esophagitis. So her GI map test results, starting with the first page, pathogens, shows the presence of the two C. difficile toxin genes, C. diff toxin A, C. diff toxin B. Just a side note is, of course, in this case, she reports constipation, not diarrhea. So she does not have the typical sort of classic expected symptoms if C. diff were causing an outright infection. So it appears that likely this is either a subclinical type of infection or she is possibly just a carrier. Just a side note, because this is a DNA test, basically toxins A and toxins B are referring to the genes that potentially can encode the toxins. It doesn't necessarily indicate that this patient is actually producing those toxins. So again, it's possible that certain patients can be carriers of C. diff. But of course, just the presence of C. diff does beg the question, why is it there and why does it appear to be growing to higher levels? So we should be able to get some insights here from looking at the rest of GI map. And here we go with the next page. We already see one of our first big clues, which is the presence of H. pylori. Now again, in this case, H. pylori is not flagged as especially high. It's actually quite a bit lower than the cutoff level before being considered officially high. But just like some of these other pathogens that we often see present, but not necessarily at high levels, such as Giardia, as well as Candida, they still can have an impact even if we don't detect them at high levels in stool. And part of that discrepancy may be due to the fact that many of these pathogens and opportunists are primarily active higher up in the GI tract. So we're seeing them somewhat indirectly when we're looking at them in stool. So just kind of a side note. And we also do take that into account in terms of the rest of the test to see, even though H. pylori in this case is relatively low, do we see an overall impact that still suggests that it is having some sort of negative impact on the other markers of the test, as well as potentially patient symptoms. We also note here that a couple of the virulence factors are positive. So H. pylori is present, C. diff was present. In terms of normal bacterial flora, we do see this common pattern that we often see with reduced digestion and possible SIBO, which is elevated Bacteroidetes and Firmicutes. And then looking at the opportunistic bacteria section page, we see a number of things that are elevated. So once again, you can see that Enterococcus is elevated. Morganella is present at a high level. Pseudomonas aeruginosa is also present at a high level. And then Streptococcus. So we do see more or less the expected reduced stomach acid pattern. And there are probably two factors at least that are contributing in this case, possibly three, to the reduced secretory activity of the GI tract. So there's the presence of H. pylori, which is known in chronic infections to frequently contribute to hypochlorhydria. She has a history of proton pump inhibitor use and also a high stress level. So all those combined are probably contributing to this overall reduced digestion pattern. One other quick side note is that Morganella has been associated with production of high levels of histamine from the amino acid histidine. So if patients have issues or suspected issues with histamine intolerance, Morganella can be something that may be a contributing factor. Also, a little further down under the potential autoimmune triggers, we see that Klebsiella pneumoniae is present. I'll talk a little bit more about that later on in the webinar, but that's also a potential marker for reduced stomach acid. And then also Prevotella copri is present at relatively high levels. And we do know that that particular species depends quite a bit on carbohydrates as its main food source and appears to be elevated, something we see quite a bit clinically when we suspect that carbohydrates may not be digested as well as they should be. In this case, we also see that Candida is elevated. This is something that we often see along with H. pylori and this overall reduced digestion pattern. And so it's thought that at least part of that contribution or link to the overgrowth of Candida, once again, has to do with a reduction in the digestion of carbohydrates. We can also see here that blastocystis is significantly elevated, and we also have the presence of Dientamoeba fragilis, so some additional parasites. Once again, this is a scenario that we commonly see when stomach acid is compromised. And it's actually common in many patients to see quite a few different pathogens and parasites present, along with the presence of H. pylori. So in this particular case, as I mentioned, there may be several factors affecting digestion relating to PPI use, H. pylori presence, as well as stress. So it's possible that all three of those together are kind of creating the perfect storm in terms of really significant impacts on digestion that's leading to this sort of widespread dysbiosis. We can certainly see there's an impact in this case in terms of intestinal health. A couple things to note here. Elastase actually looks normal in this case. Again, I mentioned that the levels that we're looking for tend to be, in terms of optimal, tend to be about 500 or above, and this is certainly above that number. So pancreatic function itself appears to be relatively good, fairly optimal. But what we do know is actually a large part of digestion, of course, is carried out by the small intestine itself through the activity of the brush border enzymes. And so that actually can be negatively impacted while pancreatic function is actually okay. So there can still be a significant impact in terms of digestion involving more of the activity of the small intestine. That's something actually we're going to focus on a bit more later in the webinar as well, in terms of some details around the digestive activity of the small intestine. But in this particular case, we can see that there is a little bit of occult blood at a level of 52, with the cutoff being around 10. So that's flagged as high. So that's a concerning factor, suggesting that there is a source of blood in the GI tract. It's possible that it may be due to the activity of H. pylori. We did note that there were a couple of virulence factors present, so that may be one contributing factor. We also noted that C. diff was present. It doesn't appear in this case that the symptoms are really consistent with C. diff infection being significant, but that may be something, again, to further explore, because we do know in certain cases, of course, in outright C. diff infection, that can cause a form of colitis. In addition, you can see here that secretory IgA is significantly elevated, as well as anti-gliadin IgA. So it is common in terms of just general digestive dysfunction. When you think about low stomach acid impacting the digestion of proteins, in particular, proteins, of course, are the main antigens that are involved in food allergies, food sensitivities. So when those proteins are not fully digested, that can lead to an increase in the antigenic load in the small intestine, and especially combined with the potential for leaky gut. We did also note that candida was present at a high level, and candida is known to contribute to leaky gut. So you have this sort of perfect storm where you're not digesting your antigens as well, your proteins, and then you also potentially have leaky gut. That's going to create a situation that's ripe for reactivity to foods, including potentially gluten. And then just lastly, I want to note the final marker, calprotectin. Again, that's not officially flagged as high, but it's really close to that level. So this would be considered a somewhat elevated level of calprotectin, kind of a moderately high level, which in this particular scenario is certainly not surprising, given that we see significant dysbiosis, significant reactions potentially to food antigens, et cetera. So it looks like chronic low-grade inflammation is part of the picture here as well. Okay, so I just want to go back to a little bit more focus on research to kind of flesh out some of these observations a bit more. So in particular related to food sensitivities, which we were just talking about, this particular review article is an excellent recent review article. Just came out last month, and the title is Mechanisms by Which Gut Microorganisms Influence Food Sensitivities. And in the article, they say one mechanism through which bacteria could affect immune responses to dietary components is through bacterial metabolism of antigens. This aspect is of particular relevance in celiac disease, in which proteolytic resistant gluten proteins are the undeniable trigger of T-cell mediated inflammation. And they go on to say several studies have shown that the human intestinal tract, including the proximal small intestine, harbors gluten-degrading bacteria such as Rothia species or Lactobacillus species that are able to utilize non-digested gluten peptides. Indeed, depending on the type of bacteria present, the end result would be increased or reduced immunogenicity of the produced peptides. So this is really an interesting aspect of talking about the interaction of the microbiome with digestion. We tend to think of, pathogens, as we've been talking about, as a possible cause of reduced digestion or digestive insufficiency, and also imbalances in the microbiome or dysbiosis being a consequence of that process potentially. But the microbes actually can also potentially play a role in determining the effects of basically foods and food antigens and how they're digested. So basically, the microbiome can also play a role directly in digestion and affect how that process happens. So there's a couple species mentioned here in this article, in particular Lactobacillus, which is important for helping to reduce the antigenicity of various proteins, including gluten. And this second article is titled Duodenal Bacteria from Patients with Celiac Disease and Healthy Subjects Distinctly Affect Gluten Breakdown and Immunogenicity. So this gets into a little bit more detail here of which species so far have been identified to improve the immunogenicity of gluten peptides or make that situation worse. And in this article, they say, we investigated gluten metabolism by opportunistic pathogens and commensal duodenal bacteria and characterized the capacity of the produced peptides to activate gluten-specific T cells from celiac disease patients. Pseudomonas aeruginosa, an opportunistic pathogen from celiac disease patients, exhibited elastase activity and produced peptides that better translocated the mouse intestinal barrier. PSA is their shorthand for Pseudomonas aeruginosa. PSA modified gluten peptides activated gluten-specific T cells from celiac disease patients. All right, so let's go back up and take a quick look at the results here. So we can see for this particular patient that Pseudomonas aeruginosa is actually present at a high level. So in this context of reduced digestion, that's potentially delivering more protein antigens into the duodenum, and then basically through the activity of this particular organism, Pseudomonas aeruginosa, if gluten is being consumed, then that can result in a worse situation related to gluten sensitivity and celiac disease. So again, that may be one of the contributing factors to this high level of the anti-gliadin IgA. So another connection potentially to make here is between the presence of Pseudomonas aeruginosa and also the anti-gliadin IgA. Let's go back and take a quick look at lactobacillus. In this case, the lactobacillus was fairly normal, so that's actually a positive result because lactobacillus actually can convert some of those potentially toxic gluten peptides that are produced by Pseudomonas into less harmful peptides. But we do see cases where lactobacillus is low at the same time as Pseudomonas is high, and that would set up potentially a situation that may be more likely to result in gluten sensitivity or possibly even celiac disease. Okay, and that's the point here in this final excerpt from that article, which is in contrast, lactobacillus species from the duodenum of non-celiac disease controls degraded gluten peptides produced by human and Pseudomonas aeruginosa proteases, reducing their immunogenicity. And this is just a figure from one of the articles that basically illustrates that same concept, so I won't spend a lot of time here, but basically you can see that starting at the top, we have human proteases acting on gluten. Basically, gluten is very hard to break down, so that breakdown is only partial. And then through the activity of Pseudomonas aeruginosa, that can break that down further into these smaller peptides that actually retain their immunogenic properties, so basically their toxic properties, but that now can more easily penetrate the epithelial barrier. So if you have this sort of perfect storm of conditions all coming together, including in this particular patient's case, I think there was also candida, which causes leaky gut, and other factors that may also increase intestinal permeability. That's just going to further enhance the ability of these peptides to get through and create an immune response. Whereas in a more balanced microbiome, where there are adequate levels of lactobacillus and other factors are coming into play to kind of mitigate that whole process somewhat, then basically lactobacillus can further degrade those immunogenic peptides down into harmless breakdown products that then basically don't stimulate the immune system. Okay, so one more quick example here. This is a male, 37-year-old, very high stress, severe reflux, PPIs, SIBO-like symptoms, etc. And this is basically a patient that has the presence of C. diff at fairly high levels in terms of the genes encoding the toxins, positive for H. pylori, a number of different opportunistic microbes present here, including the ones that are indicative typically of low stomach acid and reduced digestion. So we can see Enterococcus is present, Streptococcus is present, Pseudomonas that we just talked about is present, and then a few others as well, including Klebsiella, which is one that we're going to talk more about. So that's one I want to kind of highlight here. But overall, definitely a typical kind of expected pattern when H. pylori is present and active, including an increase in C. diff. In this case, Candida is also present, but not at a particularly high level. We do see that secretory IgA is elevated. Anti-gliadin is kind of creeping up. It's not quite at the cutoff for being considered high. And then calprotectin in this particular case is also notable for being elevated as well. Also, just a side note that elastase in this case is looking fairly good. So the digestive impacts are likely to be mostly focused on the small intestine and not so much the pancreas. So this is a research article that just came out recently, kind of fleshing out the role of Klebsiella in the gut. So we just talked about Klebsiella being elevated in this particular patient. You can see Klebsiella as a group here is at 1.49 e to the fourth, which is about almost an order of magnitude higher than the cutoff. And then also Klebsiella pneumoniae is also present, but not quite at the cutoff level. So going back to the research article, they say strains of Klebsiella species isolated from the salivary microbiota are strong inducers of Th1 type cells. Those are pro-inflammatory cells. When they colonize the gut, these Klebsiella strains are resistant to multiple antibiotics, tend to colonize when the intestinal microbiota is dysbiotic, which we can see plenty of evidence of in this case, and elicit a severe gut inflammation in the context of a genetically susceptible host. Our findings suggest that the oral cavity may serve as a reservoir for potential intestinal pathobionts that can exacerbate intestinal disease. So this is really an important point because when we think of the consequences of reduced digestive activity, especially hypochlorhydria, one of the functions of stomach acid is not only to help kill off pathogens that are coming in from external sources, in particular through food that we're eating, but also to kill off these various pathobionts or opportunists or pathogens that may be present in the oral cavity or possibly the respiratory tract that would be passing through the stomach and normally through the activity of stomach acid wouldn't be able to efficiently colonize the gut. But again, when you have this perfect storm of reduced digestion plus dysbiosis, you create this situation where not only do they survive, but then they can colonize the gut and then produce inflammation. We did see in this particular example that calprotectin was elevated. This is another, this is actually just a case report that was in a recent journal, the British Medical Journal of Gastroenterology. Just want to highlight a few different resources here that kind of talk a bit more about this role of the small intestine and the interaction with various pathogens in terms of how we can better interpret that when we're looking at GI map results. So this particular article is titled Improving Basic Skills in Celiac-like Disease Diagnosis, a Case Report. Just jumping to their conclusion, they say, this case report shows how celiac disease diagnosis can sometimes be manifold. Intestinal villus atrophy alone may not automatically establish a diagnosis of Crohn's disease, or celiac disease in this case. In the present case, the clinical scenario could be fully explained by giardiasis. Indeed, different diagnostic tools and a multi-step approach have been used to determine the final correct diagnosis. So this is really speaking to the fact that one of the advantages of tests like GI map is that we can actually see potential contributors to what you may be thinking might be due to some other cause. For example, in this case, celiac disease can be mimicked by giardiasis, so Giardia infection. This next article is titled Crypt Hyperplastic Enteropathy and Distal Duodenum in H. pylori Infection, report of 2 cases without evidence of celiac disease. And in the article, they say Helicobacter pylori is recognized as one of the most common bacterial infections worldwide, as associated with a significant upper GI tract pathology, mainly gastric related, but also in the duodenum. Duodenal mucosal inflammation with increased densities of intraepithelial lymphocytes is well described in Helicobacter pylori infection. In fact, the inflammation is similar to that of early developing celiac disease. So here's 2 different pathogens that can produce pathology that mimics or looks similar in some ways to celiac disease. So just something to take into account, that these really can have significant impacts, and that often what we may be thinking might be celiac disease could in fact be due to certain types of enteric infections. This is actually just kind of a summary of some of the various factors, including these different types of pathogens that can all cause small intestinal villus atrophy. And again, as you may note at this point that because we know that the small intestinal villi are important both for absorption as well as digestion due to the brush border enzymes, anything that's impacting the function of the small intestine, especially in the duodenum, can actually cause or contribute to maldigestion and malabsorption. So I just highlighted a few here, but you can see through this table that there's a number of different factors that have been identified that can contribute to small intestinal villus atrophy. In terms of infections, H. pylori and Giardiasis are two that we just talked about, but also Cryptosporidia can contribute to a similar syndrome. Of course, then nutritional deficiencies, it's sort of a chicken and egg scenario because we know that maldigestion, malabsorption lead to nutritional deficiencies, but in turn, those deficiencies can lead to damage to the small intestine and then further fuel that process. Certain drugs, such as NSAIDs, can contribute to that pathology, as well as SIBO itself. So again, you can imagine many of these are sort of vicious cycles once they get going. Also, just of note here is a relatively recent study titled Use of Proton Pump Inhibitors and Subsequent Risk of Celiac Disease. And they say in their results, prior proton pump inhibitor prescription was strongly associated with celiac disease. Patients prescribed both proton pump inhibitors and histamine 2 receptor antagonists had a higher risk of celiac disease than those prescribed proton pump inhibitor use alone, or histamine 2 receptor antagonists alone. And then they go on to conclude exposure to anti-secretory medications is associated with a subsequent diagnosis of celiac disease. The persistence of this association after excluding prescriptions in the year preceding the celiac disease diagnosis suggests a causal relationship. So again, just highlighting that there's potentially a lot of interactions between these various factors that can affect digestive function and contribute to digestive insufficiency. All right, so we're just about at the end here and wanted to draw your attention to a resource that we have available on our website. This is actually a PDF that was made available after a previous webinar, and it basically includes information on how to recognize the three main types of dysbiosis patterns that we can see with GI map. And so the three different patterns are insufficiency dysbiosis, inflammatory dysbiosis, and then digestive dysfunction dysbiosis. So that is this part of the document. And just kind of as a quick summary of what we've been talking about today, that's in this summary at the top of the sheet. So I'll just go ahead and read that now because it's a good summary of everything that we've talked about so far, which is dysbiosis associated with a digestive dysfunction is very common and is often due to low stomach acid or hypochlorhydria, insufficient bile acids, which we didn't really talk much about today, poor digestion, both pancreatic insufficiency and or brush border enzyme deficiency, reduced absorption, and altered gastrointestinal motility. Altered digestion motility can result in imbalances in the microbiome, characterized by overgrowth of certain species. And then there's a list below that, and this is zeroing in on the list itself. So just as a quick summary, we know that various pathogens, when they're present, some of them can actually contribute or cause issues with digestion, digestive insufficiency. Of course, we mostly talked about H. pylori and Giardia, but other pathogens may as well, such as Cryptosporidium. And then in turn, the presence of pathogens, especially at the lower level, where they're not necessarily contributing to pathology directly, may be a result of hypochlorhydria. Then there's H. pylori, which of course we've talked quite a bit about here with or without the virulence factors. Normal flora, typically the ones that we tend to see overgrown at high levels, sometimes low, but usually high, would be Enterococcus, Lactobacillus, and Clostridium. In terms of the phyla, we often see one or both of the phyla at high levels when digestion is not optimal. And then opportunistic bacteria is really the section that we focus in on most, where a lot of these tend to be fairly consistent across different types of digestive insufficiency and malabsorption. So we frequently see Bacillus elevated. Enterococcus and Streptococcus are probably the two most common. Those are also the two that are most often cited in research as being elevated when stomach acid is not sufficient. We often also see Morganella, Staphylococcus, Klebsiella. Again, that's an oral species. So for it to get down into the gut in large amounts, Usually there's kind of a couple steps required. So one would be the hypochlorhydria, allowing it to pass through and survive at higher levels, but then also dysbiosis in the gut that allows it a niche to colonize. Prevotella copri, which typically is more of a sign of reduced digestion. Candida is also a sign of reduced digestion, especially of carbohydrates. And then various parasitic protozoa. So it's not entirely clear why we tend to see them under conditions of reduced digestion, but it's also possible that those undigested foods tend to overfeed certain opportunists, including parasites. Then in terms of intestinal health markers, we often but not always see elastase reduced. Of course, that's confirming that overall digestion is impacted, especially in terms of the pancreatic output. But as we just talked about earlier, sometimes that can be normal, and yet we still see a reduced digestion pattern, and it's thought that that's likely due to some sort of functional impact on the brush border of the small intestine. Also, we frequently see a high steatocrit, which is a measure of fat malabsorption. Typically, that can be either due to pancreatic insufficiency, so a lack of lipases, or a reduction in bile acids. Then, of course, there's a wide range of potential symptoms. Among the most common, of course, are excessive gas and bloating, stomach or abdominal discomfort or pain, a feeling of fullness after a meal, heartburn or reflux, constipation or diarrhea, depending on the details, possible SIBO, and then an increased incidence of food sensitivities and intolerances. And of course, beyond that, there can be a range of systemic type symptoms, anything from brain fog to skin issues, skin rashes, joint pains, etc. So again, kind of a whole cascade process that we potentially can see basically by assessing a patient's gut using GI map. One last thing before we sign off is this is actually part one of a two-part webinar series where we're focusing more in this particular segment on GI map and the patterns that we can see with GI map. There really are all sorts of details that we can dive into in terms of the particulars of what specifically may be involved in a given patient. And of course, this is really where the concept of precision or personalized medicine really comes into play, because it turns out that, for example, mutations in the various genes that encode digestive enzymes are relatively common. And one of them in particular was recently linked to an increased incidence of inflammatory bowel disease and IBS. So that's something that we'll be talking about more in the next webinar. So thank you so much for listening, and I want to direct you to our website for additional resources to learn more about interpreting GI map and the resources that we have there, including webinars, articles, and our interpretive guide. So thank you so much for listening, and have a great day.